That looks at both the financial and operational sides of success. Please welcome our hosts, Dan Paulson and Richard Veltre. Dan is the CEO of Envision Development International, and he works with leaders to increase sales and profits through great cultures with solid operations. Rich is CEO of the Veltre Group and a financial strategist working with companies to manage their money more effectively. Now on to the podcast.
Hello and welcome to Books in the Biz. Alice, thank you again for that wonderful introduction. We have a guest today. Ben Zang, how you doing?
I'm well. Thanks for having me.
Excellent. Rich Veltre, how you doing?
I am good. Very good.
You are good. You are good. All right. Excellent. Ben, you're going to talk about one of our most favorite subjects out there, health insurance.
This is absolutely the party starter, for sure.
So when you are going to your 4th of July party, because this is being recorded before 4th of July, a couple weeks before, this is what you got to bring up as a subject. As your buddy's sitting there frying up the brats and cooking up the burgers, let's talk healthcare.
Yeah, why not? Everybody's favorite subject.
Yeah, but you got a unique approach. Well, I guess it's not unique approach, but it's probably something most people aren't aware of. So why don't you start by telling us a little bit more about your company, what you do, and ultimately the kind of services you offer that might be unique to some business owners.
Sure. So my name is Ben Zang. I'm a professional benefit consultant. I work for a company called Transition Health Benefits. And so it's a boutique firm. We're uniquely positioned to be able to do both group and individual. We're a smaller firm. We are not bought up by any of the big guys yet. No plans to be, which a lot of times in our marketplace, the bigger firms are coming through and kind of picking up the smaller firms. And then the issue becomes what those smaller firms did for the small businesses or medium-sized businesses within the community. Suddenly that service model isn't as profitable for the big guys as it once was for, say, the boutique firms. So our company still believes very much in the small to mid-sized market, and we're focused there and made a home there.
So with all that, what's going on in healthcare right now? Everything from large companies to small companies, it's one of their biggest benefit costs for employees. There's always changing. It seems like just when you get settled into a plan, something about that plan changes, or maybe that plan goes away and then you have to get another plan, or you get kicked off the plan you're on. So not always able to sit down or stay with your provider sometimes.
There's a lot.
How does it stabilize it?
There's a lot of fun little things, and by fun I mean like aggravating, throwing things and all that good stuff. You ever want a great book to read that will make you really infuriating? American Sicknesses does a great job kind of breaking it down. But I think you got a lot of different things going on in the market right now. I think drug spend and prescription drugs are the biggest costs within a health plan, for sure. So back in 2010, it was about a $10 billion industry. By all the records say by 2030, it's going to be about a $400 billion industry. So if you figure a 20-year market, and you're seeing a lot of really kind of innovations, but you're also seeing a lot of glut and for lack of a better term, kind of waste within that plan, right? So, and that's hitting the large employers and their self-funded plans, and that's trickling down into what we're seeing today. The interesting.
What's this waste that you speak of?
Waste. So, if I'm a drug company and I have a prescription that works pretty well, there's certain time frames that I can have it as a branded drug, where my patents say I can charge X amount of dollars towards. Once those patents run out, then they have to be able to be switched to generic, and they're kind of fair game for everybody else to be able to make and create their own thing. So a profitable runway on a drug really only has that X amount of years to do that. Well, what drug companies have done too is they've also said, well, we're going to change it and we're going to do gel coating instead of a powder coating. And now it becomes a new drug. And maybe we'll boost a little part of the percentage of this drug within the formula. And now it's a new drug, and we'll call it by the same brand name and things like that. So Bayer becomes Bayer gel coated. Tylenol becomes Tylenol gel coated. So it allows a company to extend that profit range. Profit range has a direct effect on the consumers and on the insurance spend and hospitals and everything like that. Well, one of the interesting things, and you're seeing it with a company called GoodRx, Mark Cuban has gotten into the drug game as well. There's always been a drug rebate program that allows some of the savings to be passed on. But those savings haven't always reached a consumer, right? A lot of times they get sucked up right within the self-funding or the larger insurance plans. And so insurance companies are, they're not nonprofits. They're in it to make money. And so it's been one of the ways they've been able to offset some of those costs, along with kind of pad their bottom line. So all of this has kind of hit the large employer health insurance plans. And at the same time, you've had this thing called the ACA marketplace, Obamacare, however you want to say it. And in the beginning, it was kind of a crapshoot, right? Nobody knew what they were getting into. Kind of what they thought was going to happen was all the sick people are going to be driven over here off of those other plans so that the plans become more profitable for insurance agents and companies don't have to bear that cost. Well, that wasn't necessarily the case. What they found was an audience that was a little more stable and very similar to what they're seeing on the group side. And through COVID and through the Affordable Care Act, there's been a lot of government money pumped into that marketplace. And I think people think that the government controls the marketplace. They don't. It's carriers like Anthem, United Healthcare, Quartz is a local one, WPS. A lot of those are all within this thing we call the marketplace. And the marketplace is kind of like Amazon for health insurance. It's where people bring their products and people are able to, and consumers are able to buy at an individual level. And so fast forward to 2019, where data has already started to amass. And you have to remember, the insurance companies have bean counters, right? So they know exactly how many people are going to get cancer within 100. They use the multiple of large numbers to be able to do this kind of calculation. So in the marketplace, the plans have gotten better and better and better and are now starting to be able to compete on the group side as far as pricing and plan design. And so within the marketplace, these subsidy dollars are coming in. There's also certain limits on how the plans have to run, right? You have all your critical components. Preventative has to be covered at 100%, all of this kind of stuff. And so what it's done is it's given kind of a fair and equal footing from both the group side to the marketplace. And if you look at like 2019, there's a thing called an ICHRAs created. And insurance guys like their acronyms, like Oprah gives out cars. So you get an acronym, everybody's going to get an acronym, right? So the ICHRA stands for basically individual choice health reimbursement arrangement, meaning I as an individual, I'm going to pick my own plan and my employer can pay something towards it. Well, in 2019, it was just started. There wasn't a lot of traction with it. It was really deemed a small market tool. And so the QSARA was also introduced around that time, but they changed the ICHRA in 2020 and they made it a little more flexible to be able to work within kind of the limitations of things. And so it allows you to kind of carve out different segments of your population in full-time versus part-time, salaried versus hourly, and things like this. So it gave employers a little more flexibility as to how they handled things. Well, fast forward to today, as those drug costs keep compounding and the health insurance premiums keep going up and up, and a lack of transparency on the hospital system side. And I have to remind people, remember, if you own a business and you don't get paid if you sell widgets and you sell the widget, but you don't get paid for 180 days, there's a cash flow problem there. And so you're going to charge for a cash flow problem. And that's right now where the hospitals are at too. Don't get me wrong, there's a ton of other stuff we can talk about as far as that goes, but this is not a 9-hour podcast. This is so I hope that's a broad enough picture, but I think right now, the ICHRA is far more underutilized than what you're going to see. In fact, Becker came out with a poll that said there'll be 80,000 employer plans using an ICHRA by 2025. And the marketplace itself is seeing an explosion in numbers, and that's really due to employers starting to look more seriously at the ICHRA.
I haven't heard of the ICHRA before. So
why?
That's the big question. Why? How come?
Yeah. So a couple things. One, brokers hadn't figured out a way to make money on it yet, right? So there's that.
Yeah.
Two, I think people have looked at the marketplace with 2008 marketplace, right? If we looked at the Kansas City Chiefs before Patrick Mahomes, it would be a very different story, right? And so there have been plenty of times where the Chiefs have not played well, right? But if you're only going to focus on that time period, it's probably not going to do. But the marketplace itself, I think people don't realize how good the marketplace has actually gotten as far as coverage goes. Okay. So that's one thing. I think the brokers not understanding it as well. And here's how I explain it. So imagine I have a room full of 100 business owners, and I'm trying to sell 100 business owners. Well, that's hard enough. But if I say I'm not only have to sell these 100 business owners, but I'm going to have to sell each one of their employees on the plan, that becomes even bigger for a broker, right? Mm-hmm. And so if we go back to what I was talking about before, as far as the large brokerage firms are changing the service model, because they have experts, they have pharmacy experts, surgical experts, they have all these things designed for very large employers, because that's where the money is. And so if I break it up and I say, I'm no longer going to put 5 of you in the boardroom, but I'm going to put your whole entire company in the boardroom, and I'm going to have to service you too, that's a tougher pill to swallow for a broker. So what they've done is they've started to create technology platforms like Zizzle and some of the others that allow people to go online and get access to the marketplace. And then the reimbursements kind of work in the behind the scenes there. The problem is you're buying not just the technology, but you're also allowing that technology company to pick up the commissions on the back end too. Whereas there are brokers like me, and there are others out there that are starting to say, we don't have to get double paid here. We can just make our fair wage, and an employer can save a bunch of money. So we did a case study on a group. Well, I had a small employer who, and they're kind of a unique situation, but they were a family of 10 and 2 other employees. And basically in switching from a statewide plan to an ICHRA, it saved them about $120,000. And that's just 3 people in the company, right? Compounded over the 10 that were on the back end of the plan. But that's a lot of savings. And so we have a 400 life group that we did a case study for. Their spend would have been, their savings would have been about a $4 million on the aggressive side to a $2 million on the non-aggressive side. The idea that if you're in the marketplace, the government is subsidizing part of that marketplace based on the Affordable Care Act. So when the Affordable Care Act was created, they basically wanted to say, We want health insurance to cost everybody about the same or relatively the same. So the only way they could do it is to say, based on your income, your health insurance should be no more than, say, 8 point something percent. Once they figure that out, if you're a 25-year-old, right, your insurance is much less than a 50-year-old. So that cost, there's a little bit of cost difference on an age. Also, if you're a 50-year-old and you have 5 kids on $50,000 in income, your income doesn't go as far as, say, that 25-year-old who has no kids, or a 50-year-old who's got no kids, right? So all of that works in. And so what that does is it kind of stabilizes the risk pool in a sense. And so they also have parameters in the way certain plans have to be written, what has to happen within it. And so wherever that risk kind of falls out of line, it all gets pushed into the group or the employer market and the group plans. That cost of plans have to go somewhere. So what you're seeing over time is renewals have gone up. I had a renewal on a level funded plan go from 140,000 or 140% renewal to basically, I'm giving you the go away rate. We don't want to play in your sandbox anymore, right? Go find somebody else to play with. Or to the average, which is somewhere between 12 and 25%. And so if you stack those 12% year over year over year, that is a huge increase on a smaller or middle-sized employer, right? You put it over a large employer, that's even more devastating. So the ICHRA allows you to get some of the stability in the marketplace. It also allows you to set a budget number. And so in the simplest way, it's like if I'm the employer and I know Rich and Dan need health insurance, I'm going to say, Rich and Dan, here's X amount of dollars. You go get it. You go get the insurance you need. Well, Rich is super healthy, works out every day, runs, bikes, does all that kind of stuff. And Dan just eats cheeseburgers every day and has a variety of health problems, right? You guys are going to buy different health insurances. And if my $400 goes really well for Dan, well, Rich is like, I get plenty of money and I'll just spend this much of my money and take a little bit of the employer's. And so what you see over time is because people can actually calibrate their own insurances, the costs get more calibrated as well. And I think that's a lot where some of the savings comes in, because you're not buying a one size fits all product. You're going individual to individual and saying, the amount of guys I hear, I never go to the doctor. This is money out of my pocket that I don't really want because I never go to the doctor. Great, buy less insurance. If you're more comfortable with your risk, buy less insurance. And so it gives a better product all around.
So does the company, I'm sorry.
No, go ahead. Go ahead.
Does the company have to then have some degree of a stopgap on that? I mean, I guess what I'm trying to figure in my head is, okay, so you have somebody like, let's assume that your example is correct and I'm healthy as a dog, right? And I'm crazy healthy. But there's things that come about that all of a sudden you don't know. So you bought the lesser insurance, and then does the company have any coverage for that? Like, is there some way to, because I could have a heart attack tomorrow that I didn't know was coming. I could feel like I'm healthy as an ox, and then all of a sudden I have a heart attack. How does the company have any, like, I guess it's not really a stop
have risk if you have a heart attack. And
so the risk is mine, not the employer. It's the employee, because the employee is calculating it.
So it's just like if you had two plans, you had an HSA plan and a copay plan, and that's what you gave your employees, right? Well, the HSA plan is all first dollar coverage, meaning if I want to go see a doctor 5 times, I'm going to have to pay up front until I hit my deductible. Whereas a copay, at least I'm paying a little less. Theoretically, I'm paying a little less, and insurance is going to kind of help. right? If I make the choice and I say, no, I never go to the doctor, and then suddenly, I've got ankle problems and I'm going more and more, that may hurt me a little more. But there's always still the max out of pocket. And so the max out of pockets and the plans are really designed for those people to kind of prevent them from going over that. And so from an employer standpoint, you're out of the choice game. Really what you're into now is the budget game. What's my budget? And people look at the ICHRA as kind of a cost reduction strategy, and in many ways it is, but it doesn't have to be. So I have an association who wants to be super generous with their people, and so their contribution levels are way past where the plans are, because what they want is, okay, you pick a plan, whatever's left gets to be rolled into a 213B or medical expenses, right? So you can set your generosity level accordingly. So if you're over 50 employers or a large market or a large employer, according to the ACA, you have certain affordability thresholds you have to work with. And so the broker will literally then design, basically, I've seen it where they do every age, which seems a little hefty to me, but usually there's about 10-year age brackets. So if you're 20 to 30, you get X amount. If you're 30 to 40, you get Y. If you're 40 to 50, Z, and then, 60 on, X, right? So you can set all those amounts for affordability. If you're under 50, you don't even have to meet the affordability thing. So right now, if I'm a small employer and I offer health insurance because I want to do what's right for my people, and so I'm contributing my 50%, well, if they're a lower income people, and by lower, I mean maybe from that $20 to $30 an hour pay cycle, if I'm older, say 40 or 50, well, the marketplace subsidies will be higher for me to take that plan than to take the group plan. But because I'm offered a group plan by my employer who wants to take care of me, I can't use the marketplace and the subsidies on it. If I do, I have to pay full price. I'm not eligible. So there's a lot of times where I'll walk into an employer and they'll be trying to do the right thing, but they're actually hurting their employees more than they're helping by offering a group plan.
Gotcha.
Right? And so by offering an ICHRA or other reimbursement type strategies, it allows them to kind of see the whole playing field rather than just what they're used to.
So what's the main difference that, from an employee side for group versus the ICHRA? Does the employee then have to do more work to go out and find it? How do they determine what's the right coverage? Are they going to be overcovered, undercovered? What's all that?
Yeah, all great questions. So two things. It'll happen on depending on what broker's on the plan. If you're using somebody like our firm, we have people that'll literally walk people through. Some people love going out there and looking at everything, things like that. Other people are like, please don't talk to me about it. Tell me which one to pick. Right? I always make the joke that before I got into health insurance, I used to hand the folder to my wife and say, tell me which one you want me to pick, and that's the one I'll go with. Right? So now I just say, look, if your wife's the one that picks the thing, why don't we get together and we'll go over that coverage? So if I were to put in your ages and zip codes, what would pop out for me would be about 120 plans to choose from. Nobody wants to look at 120 plans, right? And so based on what I've seen in the marketplace before, based on kind of the conversations we have, I'll probably show you 5 plans to take a look at. And then we'll go through and I'll explain how those 5 plans work. And then you'll say, I like that, I don't like that, or that makes no sense to me. Hey, can we do this? And by that time, then I just can reshuffle the deck and we'll find the plans that actually work for you. There are other brokers who have more of a technology bent. They're going to send their people to a website to do this. And then on the back end, it all gets kind of done that way. The problem with that is you're still leaving, there's no insurance class for school. I wish there was. Like, there should be like credit card insurance, like there should be more emphasis on the trade schools. Like, I think the reality education in our school system is missing. I'm hoping that kind of comes around. There are more talks about it now than when I went to school, but we're not real educated on how an insurance plan works. And so I think when you get a chance to talk to somebody, even your HR people, they do benefits once a year, maybe twice a year, right? They have 5 weeks of it. It's near Christmas time. It's near the holidays. By the time they put it to bed, they want it put to bed. So they're not really all that keen on trying to look and see how it is. And it's a vast majority. Like, this is a generality. I'm sure there are benefits nerds in all walks of life. We love those guys. I'm not saying they're not out there. But for the most part, nobody likes kind of dealing with this. It's scary. It's confusing. They don't make it easy. So when you have somebody who can kind of talk to you and break it down, I think that's a huge benefit. We used to go
I
ahead.
see a lot of don't rock the boat. So,
Yeah.
for example, if it's your health plan and it's a health plan let's say for the last 5-10 years, nobody really wants to change it because, again, you've got your doctors, you're familiar with how the system works,
Mhm.
you're familiar with the costs, but then there's that, you get that updated estimate for the upcoming year, and all of a sudden it shoots up 40-50%.
Yeah.
Now you start to panic because, okay, we can't keep the same policy we have. We got to find something different.
Right.
When you look at that from, I guess here's the biggest question I have. So you have your group plans, you have your individual plans through the marketplace. You've said they're both really kind of very similar demographics, which is different than what originally thought. How come it's so much cheaper over here? You kind of talked a little bit about subsidizing. How much is really subsidized on that?
Well, it depends on a lot of factors. That affordability calculation kind of plays into it, but there's a ton of money over on the plan. Some of those subsidy monies are up to be looked at in 2025. I have a hard time believing any politician's going to run on the fact of, hey, I'm making health insurance less affordable, please vote for me, right? So I have a hard time seeing how that's going to kind of go away or get changed, but I could be wrong. The affordability really comes into being able to count that calibration side. So if you're running the same plan year over year and your 20-year-olds are paying for more than your 20-year-olds kind of get the worst end of that deal, right? Unless you're saying we're going to raise our deductibles and our max out of pocket so high so it's affordable for everybody. And then us older people are getting screwed, right? We have families, we have costs, we have prostates or breast cancers or things that start to loom as we get more down that path, right? And so we lose out on having good insurance to make it affordable. And if it's good insurance, it's not going to be affordable for those that really don't need it, especially at a time where cash flow isn't necessarily the easiest in our 20s and 30s, right? So I think a lot of the savings kind of comes in that calibration. I also think the savings comes from people being able to choose what they want, right? I think there are a lot of people that are really healthy that are like, I'd rather have an HSA plan than a copay plan. And then if I have, as a broker, if I'm giving an employer and that employer wants multiple plans, well, I know all my healthy people are going to go to the HSA plan and all my less healthy people are going to go to the copay plan. Well, now I know I have less healthy people on my insurance plan. And what am I going to do as the insurance company? I'm going to cover my costs. So they're all going to go up. So the health and the HSA is going to go up a little. The copay is going to go up a little. All of that stuff kind of adds into the thing, So when you look at selection, that's why participation rates are such a big deal to insurance companies. Because if the participation rates in your insurance plan aren't great, it means that only the really sick people are going to sign up, which means now they know there's going to be a greater cost. And I think the ICHRA takes all that kind of administration away. So what ends up happening is every open enrollment season comes, they said, okay, here's your allotted amount, go nuts, go get the insurance plan you need. And then within that system, one of the things we didn't talk about, which is a TPA, which is another, acronym alert, right? Third party administrator. Somebody's got to pull the money from an employer and bring it to the employee. And they have to make sure that the employee is submitting a valid receipt, right? I'm not going to Walgreens, getting my favorite bottle of Jack Daniels and my favorite animal Australian wine and sending it in as a medical receipt. It's a valid either medical expense or premium that I get reimbursed for. And then the TPA starts to move the money from here over to the employee, and usually within about a week's time. The other thing
is TPA necessary for also paying the premiums as well?
No. So there are some TPAs that pay the premiums, and that gets a little convoluted, and there's some risk there. A lot of the technology platforms will do it. NextBen will do it, things like that. And employers that want to try and make it convenient for their employees tend to lean a little bit towards there. There's some issues with that. If things get messed up, then you're on the hook for messing up somebody's insurance policy. Whereas if you're doing it kind of in the model we found that to be most effective, I as an employee pay my thing and then I get reimbursed back. There are ways to kind of make sure the reimbursement gets there before, so it's not such an outlay on employees. But this way I control it. It's just kind of the same principle of you're a pizza driver, right? You use your own car, and I as a pizza owner want to help cover a little bit of your car insurance. So you pay your car insurance and I'll give you a reimbursement for it, right? So that's the way the ICHRA works. That, and when you put the empowerment on people, there will be some people that just will be like, well, I don't want to pay for insurance. I just won't pay for it, right? But then it's a cost that's not coming out of the company's fund, and they're not being penalized because somebody would rather take the risk on themselves from an enrollment standpoint. They're not penalized for that lack of enrollment either. So it kind of strips away some of the fat that can get into the plans unknowingly, I guess, or inadvertently.
Okay, so that's really where the savings comes in then, is that ability. If somebody doesn't want insurance, they don't have to get it. There's no requirement for the business to then pay for that individual's coverage as they would through a group plan, where they have to basically chip in for everybody that's eligible. Is that correct?
Yeah, and the plan design is the biggest thing, right? So if I'm an employer and I think my top talent all want a $500 deductible and $4,500 max out of pocket, or $4,000 max out of pocket. Well, if I'm 25, I don't need that much insurance, right? Especially if I'm healthy. So that's a lot of where the savings comes from, because if you give me the choice, I'll take the $8,000 HSA plan all day long, and maybe I'll buy an accident policy to cover my risk, because I know I'm not dropping dead of a heart attack anytime soon, or cancer, right? I think my biggest risk, 25-year-old, is probably going to be a car accident. So I can insure my risk this way instead of the other way. And I think that's where a lot of the savings is because people can choose what they need and what they don't need. You also, if you're in the marketplace, your pool is millions. And so if I'm a little bit on the sicker end or need a little more coverage, I can get that coverage. I can find that coverage there, and my employer's not having to kind of eat it on the back end premiums because of my health condition. So the reimbursement kind of makes it kind of a level playing field for everybody.
So is this available nationwide?
It is. There's some areas where it works better than others. Wisconsin, it works great in. There are some certain individual markets have a stronger state market that really didn't seem to disintegrate when Obamacare kicked in, because there were a bunch of individual marketplaces before the marketplace. Some got pulled up into, some kind of stayed off to the side, some have kind of grown. So there are some that it doesn't work as well in. Like Madison's an interesting example here in Wisconsin because they're so HMO driven that they tend to be very affordable on just a fully insured plan, which is very unusual. So at the other firm I worked at, we were more on the larger side. And so we would do analysis based on the HMOs in versus a self-funded platform, which is kind of a more cost-controlled, buy the insurance you need as a company. And the HMOs beat it hand over fist. So there are those little microclimates within the country that ICHRAs may not be the best thing. A self-funded plan may not even be the best thing, and it may be something like a fully insured. But they're very few, and they're kind of microclimated, depending.
So how would you know? Do they need to talk to somebody like you?
Get a good broker. Yeah. Okay. Get a good broker. And so if you're looking at ICHRA plans and I'm not your broker, or you're in other states and things like that, I think you want to look at, especially if you're on the small to mid-size, I think you want to look at, are they trying to push me into a platform like Zizzle? What's the other ones out there? Take Command, things like that are already charging me. That are charging you, it shouldn't be any more than a $5 per employee per month on the TPA side. Your broker already gets a back end commission from the marketplace that they deal with, and their commissions are relatively the same from carrier to carrier. So it's not like I'm just going to write Anthem because they give me the most money, right? It's pretty standard across the board, which is good for a consumer because it means your broker doesn't have any skin in the game as far as where they're trying to push business. They should do what's best for you. And since we're not all paid up front on our commission, it's paid over time. Really good, smart brokers are trying to play the long game. They want you for a year, 2 years, 3 years, 5 years, because that's where they'll start to make their money. So for me, I'm always a little reticent of technology platforms. It's not that they don't have a place. They do, absolutely. But anytime you start to have administration fees, technology fees, platform fees, all of that kind of stuff, there's a lot of bloat in that budget. So that's one of the things I would watch out for when you're looking at an ICHRA plan. The other thing is I would want to know what the customer service model is on the back end. You know, is there a live person to talk to? Can somebody help my employees choose plans? Things like that. Because I think that makes the biggest difference. There was an interesting stat that said you could have a very, very rich plan, but if you poorly communicate it, your people won't like your benefits. But you could take that same population, take a worse plan, and communicate it very well, and where people understood the plans, and they would think it's the best plan in the world. So communication is one of those things that I think employers overlook. And so picking a broker that will actually spend some time with your employee base is a big thing.
All right. Rich, you're pondering. I see you pondering.
You made me talk a lot, so there's got to be a ton of questions.
No, I don't think I have any tough questions. I mean, this is a new concept for me, and my wheels are spinning. Unfortunately, I'm trying to focus on everything you're saying and taking it all in, and it keeps coming back to me like, you have to get a new health insurance plan on 1/1 of 25. So my head is actually like split. Half of me is actually thinking about, okay, is that something that I can implement? Is that something that's going to help me here? Because I'm in a new world. I feel like I'm in a new world, right? And having to come up with a new set of benefits it's just daunting. It's a daunting task. So I'm glad to hear that there's new things coming out, though, that seem to be addressing, as you said, the scary part was, Marketplace 2018,
Yeah.
That just, if that's what I have to go in and deal with, I'm doomed.
Yeah, I mean, there's a bunch of little options out there, I think. And the hard part is we're getting creative for the better and for the worse, right? And so you're going to hear terms like private insurance thrown around. Run, just run. So I think people don't understand what private insurance is most of the time, unless they're actually working through the marketplace or through a reputable carrier, and there are off marketplace plans that have some of those things. But when you go off marketplace, you need to be more cognizant of the fine print. And so some of the UHC Golden Rule is one. And their plans are great, but they're hospital indemnity plans. And I think people don't understand the difference. And so what I tell people is okay, would you buy a car insurance policy if it only covered the left hubcap, the right front hubcap, the trunk, the hood, none of the undercarriage? You get your windshield, your driver's side airbag, but not your passenger side airbag. That's what these hospital indemnity plans are. So if you've got a crystal ball, or you're pretty sure you know where your risk is going to fall, great, have at it. Just know there are blind spots, right? Whereas the other, in the marketplace and some of the group plans, they've done a better job at kind of at least being a little more transparent in the blind spots. I think transparency is always the toughest part about this whole game, right? And so I think a good broker is going to break down kind of the lack of transparency. And if they can't, they at least should let you know kind of where it is. This is your gray area. This is your blind spot. This is where your risk is going to be.
Yeah.
So, Ben, can you help people in other states, or are you specific to?
No, I can. There are Florida right now. Our agency is licensed in 48 out of 50. I myself am licensed in 5 different states. Licensing only is an issue in weird states. Most of the time there's a reciprocal licensing within the states because there isn't that big of a deal. Like Florida is an interesting one because Blue Cross Blue Shield, or Florida Blue down there, doesn't play well with out-of-state brokers. They want you to use in-state. So it's sometimes
that's what you mean by weird.
Yeah. So okay. There's just little picadillos in each state, right? And so you just kind of have to know, and you go in, and I think good brokers have a network of other brokers within the states where we're like, hey, we don't play as well in this area. Do you mind taking a client down here? Can you hand it off? Because I think it all comes back around to you. If you do what's right for the client, it'll come back. And,
Right.
But yeah, so across the country, ICHRAs work in more states now than they don't. I mean, people are getting really creative. Like there's what's called a reference-based pricing thing. Will not work in Wisconsin. The health systems have already come out against it. But basically it's payment on a multiple of Medicare. but it's same day payment to a hospital. So if we go back to the cash flow problem, right? If I say, Rich, I'm going to buy all your widgets and I'm going to pay you in 6 months. If Dan comes along and says, I'll buy like 20 of your widgets, but I'll pay you right now, but I want a little bit of a discount, you may take Dan's money right now, right? And so hospital systems have been doing that. Illinois will do it. Texas will do it. And so there's some funky stuff out there that people are trying to be creative as far as how to solve this issues. The trick is going to be looking to see where the blind spots are.
Gotcha. So, Ben, it sounds like you would be a good person to get a hold of to at least figure out where to start with all this. How do they get
I would love that. Yeah. So easiest way is I'm on LinkedIn. My cell phone is on my card. Dan, you're welcome to put it up on the contact stage, things like that.
Sure.
My email is ben@thbwi.com. So pretty easy, like Transition Health Benefits Wisconsin.com.
Yep. And like you said, whether it's Wisconsin or not, you have the access to at least 48 of our illustrious 50 states. So you can at least provide a get-go or get started point.
Yeah, and if I'm not the guy, I'm happy to get you to the guy that can help you, right? And so excellent. I think the biggest thing on things is take a look at everything. When I present to a client, I'll present all 4 options, even though there are certain clients I know the ICHRA's just going to kill it for. But
Excellent. Good. Rich, how do they get a hold of you?
Email's always best. rveltry@veltrygroup.com.
And my email is way too long, so just go to danpaulsonletsgo.com. There's a form there you can fill out that'll set up a meeting.
Let's go.
And let's go. Exactly. So, Ben, thanks again for joining us. Thanks for educating us or trying to. My eyes are now glossed over because there's a lot of information when it comes to healthcare, but I think you've given people another alternative to look at, so I really appreciate it.
Thanks so much, you guys. We appreciate you having me on.
All right, guys. We will talk to you later.
Right.
Take care.
Sounds good.
All right.